이렇게 몇 시에 바꿔주실래요? 58분에 9분? 아, 아, 아. 저 59분. 바꿀까요? 저 59분. 바꿀까요? 화면 공유.
네,
화면 공유. 갑니다. 갑니다. Okay, we're waiting for the OK sign. Okay, we're waiting for the OK sign. Okay, go.
Sally up, green Sally down. Left on the start, gotta tell the ground. Green Sally up, green Sally down. Left on the start, gotta tell the ground. Green Sally up, green Sally down. Left on the start, gotta tell the ground. Green Sally up, green Sally down. Left on the start, gotta tell the ground. Green Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up, green Sally down. Left on the start, gotta tell the ground. Oh, Miss Lucy dead and gone. Left me here to weep and moan. Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up, green Sally down. Left on the start, gotta tell the ground. Sally up,
Okay, Dr. Chung.
Good evening. Welcome to the webinar and greetings from Seoul. I'm Dr. Ina Chung from Seoul, Korea. We have had 2 hours of lecture on the fundamentals of peri-implant disease and key factors for treatment. Tonight, we'll be taking questions regarding the lecture and have a live Q&A session. The webinar is of course live and interactive, and we encourage all to ask questions throughout the session. We have collected about 10 questions prior to this session and will be collecting more questions throughout the session. Let me draw your attention to the chat button on the bottom of the screen, which is where you are able to submit your questions during the lecture. So now, I'd like to start by telling you a little bit more about the speaker this evening. Professor Ki-tae Koo is currently a tenured professor at Seoul National University, Department of Periodontology. He's an expert council member of Osteology Foundation, an ITI fellow, and most importantly, he was the first prize winner in the clinical research at 2019 Osteology International Symposium. So once again, thank you all for joining us on the webinar this evening. And now, I'd like to hand it over to our speaker, Professor Koo.
Thank you, Dr. Chung. Hello, Indonesia. Good evening. I'm Ki-tae Koo from Seoul, Korea. Welcome to the Peri-implantitis Q&A session. It's such a big honor for me to have this opportunity. I thank Dentium for the kind invitation and hope everyone is safe in Indonesia. Hope you are safe and well. This COVID-19 crisis may have made us distance each other, but with this amazing technology now, the one we're using right now, I feel like I'm in Indonesia right now. So there are positive sides to this pandemic, I guess, also. Now we can meet through technology much easily and more efficiently. And I thank you for joining us today. We'll have a 30-minute to 1 hour, depending on the progress of Q&A session of the peri-implantitis session. Thank you. Okay, should we begin with the questions, Dr. Zhang?
Yes. So the first question we collected was, with a smoking patient, how do we reduce the probability of peri-implant disease?
Okay, so from Indonesia, we have received 10 formal questions, and I guess the first question was about smoking patient. Very good question, very good question, and I think we have to relate to our common sense. Smoking is not good for you, even for peri-implantitis, but I guess we have to refer to the etiology that was addressed in the 2017 World Workshop on the classification of periodontitis and peri-implant diseases. In this meeting, we discussed about the etiology of peri-implantitis. Through common sense, we know that smoking is bad for you. However, in this meeting, we were able to locate three really prominent risk indicators. That was history of periodontitis, poor plaque control, and lack of maintenance care. Smoking, however, we know that it's bad for us, but it was decided in the meeting that the evidence was not sufficient enough, so it was decided to be inconclusive together with diabetes. So, going back to the question, with a smoking patient, we know it's bad for us, but there is insufficient evidence to really say that it's a direct risk indicator. So, um, how to reduce the probability of peri-implant disease? I think the only solution would be smoking cessation. However, that would apply to only a limited number of patients. So, yes, smoking cessation would be a good solution. However, in case you are not able to achieve that, maybe in our clinic, reducing the number of cigarettes when you're smoking, when you're right after the surgery, before and after the surgery, during the healing phase, if possible, to reduce as much as possible the number of cigarettes that are being taken. And I want you to take to this study by Dr. Dewal et al. That was published in 2011. And they were looking at factors, and I talked about this during our first session. They looked at the success rates and also the factors that are decisive for the success of resective surgery after 12 months. And they were able to say that the most important critical factor was the mean bone loss at baseline. So that means it's better to start early. Early intervention is a key to success for successful peri-implantitis treatment. But also at the same time, it was the results were really bad for the smokers. So we know that smoking is bad, and we know that smoking had a big effect in this area. So I want you to take in mind that this study, the results from this study, is very important. And I don't know, just common sense. The best solution would be to stop smoking, put the patient on smoking program, cessation, and probably warn them a lot about the consequence of smoking during and after the surgery. So I think that is my answer to smoking and reducing the number of cigarettes. I think that would be important. Okay.
So smoking cessation and reducing the number of cigarettes. So
Okay.
now on to the question two. What is your non-surgical debridement protocol? Steps and local antibiotics used.
Okay, non-surgical treatment, I think could involve several steps, but I think it's common to a lot of us. We have to use instruments that are commonly used for periodontal treatment. And let me get back to you. We are so used to using Gracie curettes and also these type of ultrasonic curettes, and then we have the air abrasive units such as PerioFlow, and then we also have the laser, and also these are titanium curettes. So I think we follow the basic instruments that are commonly used for normal periodontal treatment. I usually start with for a non-surgical peri-implantitis patients. I normally use my ultrasonic with the tips with the what do you call it? The stainless steel tips. And when it's a little, the tissues are a little more flabby, and when there's more inflammation, I would use the Gracie curettes too. But at the same time, we are recommended to use titanium curettes, and I want to point out the reasons for that. Okay, these are the titanium surfaces that has been affected by scratching of or the instrumentation of different instruments. And I just wanted to refer to you. This is the plastic curette. The second one would be the airflow, which is the air abrasive unit. And then we have the Gracie curette, and we also come to the ultrasonic. So you could see through the SEM that uh, the scratches become more severe when we are using the Gracie curette and also the ultrasonic. However, uh, I don't know. It's very difficult now. The use of plastic curettes are showing some limitations because it's not strong enough, or it doesn't have that the the power actually to remove all the granulation tissue and the inflammatory tissue. So, despite all these scratches, I think I would recommend you to use if you can, it would be better to use a titanium curette. However, I think we can start with a Gracie curette. The the normal curettes we would use in a normal periodontal therapy, and that's how I would start with a the protocol would start with a instrumentation. And just to show you, this is an example of curettage, you say curettage or instrumentation, debridement with a plastic curette. And just to show you the normal steps that we would take for normal instrumentation. Okay. And then so I would do that on a regular basis. I would put the patient on a regular interval, probably every 3 months, every 3 months. If the patient is very compliant, if the patient has a very good periostatus, and also if everything is intact, good, probably every 6 months I would do a recall. However, if the patient shows at least a little bit of signs of inflammation, I would put the patient on a 3 month recall. Would have the patient in, and these are some of the ways we could approach the maintenance phase in office to deal with these type of peri-implantitis patients. The first one would be using a let's say the what do you call it? I'm a little nervous. 이게 뭐지?
Brush and top brush.
Yeah, okay. We could use the curettes. We need the curettes, and also the flossing. The
Interdental
flossing. Okay.
brush. Yeah.
Okay. And then other methods would be we could remove the plaque from the using Q-tips, maybe. Okay. And then in these type of cases, we use the cups, rubber cups with pumice to actually remove some kind of plaque. These are ways uh, we could be used to take care of that. Sometimes we have to remove the prosthesis. We could remove the prosthesis, put it on an ultrasonic, and clean it, and then reconnect it. That could be another way to treat the patient during these intervals. Okay, we've shown the electrical interdental brush. This could be another way. Okay, this is available in our market. The secret to success for this would be to actually go into the pocket. So it has to reach almost the bottom of the bucket, and then we would irrigate. We would mechanically disrupt the biofilm in the pocket, and then we would irrigate this area. So these are my steps, and also for the for the locally administered antibiotics, there are different products out there. minocycline, other types of antibiotics that are available for injection, injectable type of local antibiotics, and these are really helpful for acute symptoms of inflammation. So even though this is a peri-implant mucositis case, that doesn't mean this area won't swell. Okay, we recall this patient every 3 months. The patient will come in, but sometimes it would have a big swelling, and we have to reduce that type of swelling in this area. So I think in those type of acute phases, these type of locally injectable antibiotics are very useful. How do we inject that? It's We could inject that through a injectable type of device that are actually provided by the manufacturer. And then the secret to this is you have to reach the pocket, okay? So you start from the pocket and then you start releasing, and this area will soon fill up with the antibiotics. And then you put a gauze over this and you instruct the patient to stay away from water or no gargling, no drinking water for 1 hour, and then the patient will be okay. So this is how we would use this type. I think in your market, the product name is called Perioclin. It's probably provided by Sunstar. So these type of injectable local antibiotics are very useful. I use this case, so we are mixing the debridement phase, the mechanical phase, and these type of medication in the non-surgical phase. Okay, so this is the results at 2 years. So yeah, we frequently use this type of medication for adjunctive use when there is acute inflammation. Okay,
Thank you. So now on to question three. How do you decide either to keep or remove alien implants?
okay, this is another very good question. Okay, what are the
Now
guidelines
on to
to
question three.
make this
How do you
decision?
decide
Okay,
either to
maybe
keep or remove
if
alien
somebody
implants?
next to you, or if you have somebody you don't like, a dentist you don't like, maybe you might remove. You say this implant is failing, and you might remove it, but the ones you placed, you probably won't remove. Okay, that's a joke. Um, there is a guideline. Okay, so we have to be supported by evidence, and I refer to you. This is from Frank Schwartz's book. It was published, I think, many years ago. And when we look at this book, after diagnosis, the criteria for explantation would be, I think, two areas. One would be loss of osseointegration. So if the implant is ailing, or if it's almost failing, you probably, with a pincet, you probably know that it has mobility. Okay, any type of fixtures that have mobility has to be removed immediately. So yes, if it has loss of osseointegration, it has to be removed. Okay. Now, what about the ones that are inside and you're seeing bone loss? Okay, I think the criteria explained in this book uh, has has the bone loss relative to the fixture length. If the bone loss is greater than 2/3 of the implant length, I think it is recommended to be removed. Okay, so that really depends on the situation. If the remainder, I say, osseointegrated part of the whole fixture is less than 1/3, then it probably has to be removed. So these are some scientific backup to actually make a criteria to remove the implant. I'd like to share, okay, this is a case that are provided by, thank you.
알았어 서로를 불러왔던 것처럼 내 연락처 뒤에 내가 말했죠 내가 찾아 헤맸던 너라는 걸 우리 만남은 과거의 공식 Don't know where you were 우주에서 네 내게 주어진 운명의 증거 너는 내 꿈의 투석 Take it, take it 너에게 내면 내 손은 족해질 숙명 걱정하지 마 이 모든 건 우연이 아니니까 우리 완전 다
Okay, so easier way to remove the implant. We used to actually use very primitive ways to remove the implant. Now we have this kit. It's available from many. The kits are available from many companies. I think it's a very useful tool, and it's less traumatic to remove the implant. And now I think the technology and also all these recent developments in our area too, in our dental area too, is really making our life much more feasible and easy. So okay, so I think if we could utilize these type of instruments, it'll make life much more easier and less traumatic for the implant. So one third, okay, one third of osseo. If it's less than one third of the osseo-integrated part, okay, it is recommended to be removed.
Thank you. So on to our question number 4. I saw from your photos after peri-implantitis treatment, there's some healed implant sites with recession and thread exposed. However, exposed threads can easily cause food infection, and without the implantoplasty, how can patients maintain the cleanliness as the thread?
Okay, this is another very good question. I completely agree with you. If there's implantoplasty done to the exposed threads, I think it'll be much more, I guess, much more difficult for the bacteria to contaminate that area. So you'd be much more resistant to bacteria. However, for implantoplasty, there is a controversy. Some people are against implantoplasty, some people are in favor. But in this case, in this very specific case, I completely agree with you. I think if we have performed a implantoplasty in this type of supra alveolar peri-implant that are sticking out of the gingiva, then I think this is a good indication to do an implantoplasty. However, these type of fixtures are very accessible for the toothbrushing. The toothbrush and everything else is very easy to approach and it's very accessible. So in this case also, when you look at the patient, the position was really not good. It was placed too far buccally, and now it's sticking out of the gingiva. However, in this case, although it doesn't really look very aesthetic, I think function was more important, and the patient was able to brush this area very thoroughly. So, and then we recall the patient every 6 months or so. The oral hygiene was very good. The patient was very compliant, and the patient put a lot of effort trying to remove the plaque around the implant that are exposed, the fixture area that are exposed. And then I think it was efficient enough to remove all the plaque. So it was removal in this case. However, I agree with the concept. If we are experiencing this type of uh, the exposure out of the gingiva, I think it's a good indication for implantoplasty, and it'll be much more resistant to plaque accumulation. I completely agree with you. Okay. Okay. I think we have to hurry up a little more. Okay. Question
Uh,
5.
Question 5. What are the chances of success for keratinized mucosa grafting around the implant?
Okay. I think the concept or general idea for keratinized mucosa grafting, the chances are very high. It's very, very successful, actually. And it was addressed in the 2017 workshop by Dr. Skulian too. No, 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 that was the other one. The 2018 FDI consensus. And when you look at the paper by Anton Skulian, Dr. Skulian, uh, he addressed the importance of having keratinized tissue, and I just wanted to share you many papers, many evidence in the literature about keratinized mucosa, how if it's less than 2 millimeters, it's difficult to have plaque control. The plaque would accumulate, and it'll be easier for disease onset and progression. Okay, this systematic review by Dr. Toma, same thing. However, when you look at the consensus report from Skulian, from the FDI consensus, the best way to have keratinized mucosa would be to have apically positioned flat and then have a free gingival graft in their area. And I think the success rate, the success rate is relatively very high for this type of procedure. So it's pretty safe, and it's very predictable, and also it's probably the best way to increase the vestibular depth. If your vestibular depth was compromised, uh, in that paper, I think Dr. Skulian, he explains very explicitly that the best way would be to do a APF and then free gingival graft afterwards. So I hope I answered that for you. Okay, okay, and here's an example of this case. When you look at the left side, there's limited keratinized tissue. So what we do is we do a APF. So we do a split thickness incision, and then we we locate the flap near the mucogingival junction. So we apically displace that, and then in that area that are exposed, we take a free gingival graft from the palate, and then we use holding sutures, try to stabilize it as much as possible. The secret to success in this type of grafting would be to actually have the graft immobilized. So the most important factor would be immobilization of the graft, and then if it's done properly, like this case here, I think we could have done a little more, but the chances of having a success rate is relatively very high. So I would say it's very high. It's a very predictable treatment, and there's controversy about having keratinized mucosa. Some people in the restorative area, some are against it, but as a periodontist, we feel more comfortable having keratinized tissue. We know that it's much more resistant to plaque accumulation. The patients are able to, I guess, use the instruments or the gadgets like interdental brush, super floss. Okay, excuse me, I forgot that term. The word super floss. Okay, super flossing, interdental brush, because there could be pain if it's alveolar mucosa. If it's not keratinized tissue, this area could be very painful when you're actually using this type of instruments. So yes, it's much more resistant to plaque. It's much more, I guess it's favorable for the patient because there is no less pain to use these type of instruments that are crucial for maintaining optimal oral hygiene. Okay, now another twist to this question: could we attach the free gingival graft to this area directly to the surface, and could it be attached? Now, this was done by a student of mine many years ago, and I think it serves as a good example why this really won't happen. And we have to look at the biologics. It's critical that yes, clinic is important. Clinical uh, examples, clinical implications are very important. However, it has to follow biology. And when you look at this at the healing, okay, we could see that okay, this area has not healed. Okay, so it's really tough, and it won't work. Just adding a free gingival graft to the surface, that won't just happen. That just won't happen. What about a bigger free gingival graft? No, no, but it would probably help make this area that are below the fixture level, fixture area. You'll make it this area with it will make this area heal with keratinized tissue. So, yeah, it would help that way, but it won't. Uh, it won't adhere to the contaminated surface. So, yeah, that's a very good example. I think that my student has left many years ago. Okay. So yeah, this I've showed you during our first session. So that is my answer to your question. Okay.
So on to question six. What are the post-operative maintenance in the patient level during the period between the first and second surgery?
Okay. Between first and second surgery, okay, what do you do after first surgery? You prescribe antibiotics, and then you put the patient on
Question six. What are the
uh,
post-operative
chlorhexidine
maintenance in the
rinse for
patient level
2 weeks
during the
probably.
period
I
between the
think
first and
that's
second
probably
surgery?
similar to every one of us. However, I think there is a difference between having the implants in a transmucosal phase or actually doing a closed approach. I think there is a difference between the two. If it's a closed approach and if it's a closed approach, I don't think there's much you can do. You just clean the other areas so that the patient's oral hygiene is optimal. And you probably recall the patient 1 or 2 months later, take an X-ray, see if there's swelling and it's if the osseointegration is doing well. However, if you put the healing abutment and if you anticipate a transmucosal healing, I think the patient has to clean that area more thoroughly, whatever, by brushing. I think you could brush, okay? So you have to brush the patient's. If you would put the patient on chlorhexidine rinse for 2 weeks, however, uh, for extension of the rinse, you could use other types, maybe Listerine. The Listerine has come up with a new product with green tea, and it's does not have alcohol, so it's less abusive or less toxic, I guess, to this area. So I think you could use that. But if it's healing with a transmucosal component, then the patient has to be more efficient. They have to clean better. They could use plaque control. So I'll probably recall the patient 1 month later if it has a transmucosal component and see if the patient is cleaning very well. And also, like I said, uh, it, and it has to be clean throughout the whole dentition. The patient has to clean very well everywhere. So we have to take a look at that also. Okay. I hope I answered your question. Okay. We move to question seven.
And seven, is it possible to place an implant immediately following explantation?
Oh, yes, it is. Yes, it is. And let me just explain this to you by showing you a case. Okay. Here's a case that had an ailing implant. So we use the fixture remover by Dentium
And
to
seven, is it
remove and
possible to
to
place an
apply
implant
force
immediately following
counterclockwise.
explantation?
And then we remove the implant and now we have a osteotomy. And the only way to actually place a new implant in this area would be to place uh, an implant, a fixture with a bigger size diameter. If you removed an implant with a 5 millimeter, it's probably it makes sense to use a 6 millimeter and place another implant without any drilling. So yes, yes, it's possible, but it makes sense. It will be wise to use a size bigger, a diameter in bigger size to actually place the implant immediately after removing the implant. Okay, so it is possible. However, you need to use a bigger size. Okay.
On to question 8. How closely related are the peri-implantitis incidence and infection control?
Okay. Incidents. If we talk about incidents, we have to look to the evidence. However, yeah, if we look at it from common sense,
On to question 8.
if the plaque
How
control and
closely
the
related are
infection
the
control is good,
peri-implantitis
then
incidence and
the
infection
incidence
control?
would be lower. So yeah, from common sense, we could answer it that way. However, if you want to first look at the peri-implantitis incidence, the papers I would like to quote would be this study from Dr. Franzund, published in 2005. And you look at the prevalence of peri-implantitis, okay, with this type of criteria. And when you look at it, okay, 27.8 subjects and 12.4% of patients were suffering from peri-implantitis. Okay, that's quite high. And another study from Jansaker, and this cross-sectional study, okay, when you look at from the subject level, the prevalence of peri-implantitis is 55.6 to 77%. At the implant level, it would be 43%. So yeah, it depends on the study. It depends also where you are. I think in Korea we have uh, much more. I think Korea has the most implants placed in the world per person. So I think the more implants you place, there is a higher risk and higher possibility of having failures. So yes, the prevalence would be much higher in Korea probably, and this study by Dr. Zitzman, okay, we look at the peri-implantitis lesions identified 28% to 56% of all investigated individuals, and at all, this is at the implant level, 12 to 43%. So, yes, we are seeing a lot of peri-implantitis case. I think more in Korea. So that's not good. However, so I have said that it's important that the patients are controlled early when the patients are suffering from mucositis. And I come back to this study by Dr. Costa et al., a follow-up of 80 patients at 5 years, and they've divided the patients into two groups. One group received maintenance care, and the other did not, and much better results for the group who received maintenance care. So I think the we come back to the question. Infection control or maintenance, I think, is critical to reduce the incidence or prevalence of peri-implantitis. So yes, I hope I answered that. If we put the patient early with a very stringent protocol for maintenance, I think that could have a high possibility of reducing the whole prevalence of peri-implantitis incidence. Okay, so I hope I answered that. Okay. Now, question
Move
number
on
nine.
to question number 9. After treatment of peri-implantitis, would there be problems associated with implant stability or retention? And if there is, how do we prevent such failure?
Okay, so I've explained to you that for surgical treatment of peri-implantitis, there would be three ways. One would be to do an access surgery, okay, and another would be to try a regenerative surgery, and then third would be to do a resective surgery. It really depends. It depends how how much the how much bone loss you have, but I don't think this surgery itself would jeopardize the integrity of the implant. So the only way would be if you are if you are if you have fear that it would fail, and the osseointegrated part is less than one third. I think it's better to remove the implant. Okay, but otherwise, access surgery, resective surgery, I don't think will have any effect on that. And I want to come back. This is a case I've done. Okay, for the resective surgery. Excuse me. Okay, I'm having trouble. Okay, it's resective surgery, and what we did was, okay, we did a non-surgical phase. We come back, and then we open the flap. Now we are doing the the resective phase of the surgical phase of the treatment. So we open the flap, and then we remove all the granulation tissue, all the inflammatory tissues, and in this case, I've done a implantoplasty. If you do implantoplasty, you know that you are removing the layers between the threads. So maybe in some of the fixtures could be a little thinner than what we've began. However, in this case, even after many years, there was really no effect of this area. So no, I think, and then this is I think after many years after doing a resective surgery, we have the area very smooth, very clean. So in most of the cases, I don't think this type of surgical application would have a impact on the question was the stability or retention. So to begin with, when you have a very jeopardized implant and an implant that is very unstable, I think I recommend you to remove it as soon as possible, following the guidelines I have talked about. Okay. Now moving on to question 10.
Yeah, question 10. In your clinical experience, what do you think is the major factor causing peri-implantitis?
Okay, the major factor causing peri-implantitis, I want to refer to IDRA, okay? This is a very clever risk assessment. It was done by Dr. Heiss Mayfield. And I think, okay, periosusceptibility and history of periodontitis, I think is very critical. Also, the maintenance phase, how the patient is maintaining the bleeding on probing percentage. Also, uh, the need to intervene as soon as possible. Okay, the earlier the intervention, I think the better the results for all the cases, most of the cases. And also now we are seeing a lot of evidence that are related to prosthesis and also the position of the restorative margin relative to the bone. Okay, so we now with the risk assessment by IDRA, we know that we are seeing these type of risk indicators, and I think everything is important. Everything is important. So let me just finish off by just pointing out some of the important keys to success. I have summarized it into five keys to success. I think the first would be early intervention. So if you could control it as soon as possible, probably if you can stop it at the mucositis phase, I think it will be wonderful. Wonderful. You'll have wonderful results. Okay. So early intervention would be, okay, excuse me, a very important key to success. The second would be retrievability and embrasure space opening. So now we are trying to gather, and we are gathering more information about the relationship between prosthesis and peri-implantitis. So I think this is important. Okay, we need space for the patients to clean. Also, if it's retrievable with the screw holes, and we can remove the fixture, the crowns and the prosthesis at our convenience and clean it and maybe reconnect it. I think that could help too. So this is another criteria. Okay. Now, having my own decontamination method, I think is really critical. Okay. So you might prefer using perioflow, laser. It's up to you. It's up to you. But I want you to have a definitive decontamination methods that is useful, okay, that is customized for you so that you can achieve good results. I use a combination of mechanical and chemical decontamination methods. So, yes, it's up to you. Okay, the fourth would be keratinized mucosa. We talked about this. Okay, we're seeing swelling in this patient. And what we did was we're following the recommendation during the lecture, APF, osteoplasty, to reduce the pocket, okay? And then once it's reduced, we want to switch it to keratinized mucosa. We're not trying to cover the fixture. We're trying to change the integrity of the soft tissue here in this area below the fixture. So we are trying to transition that into keratinized mucosa, and this is 5 months follow up. And then we have recalled the patient up to 4 years. The patient is doing very well. So yes, keratinized mucosa in a periodontal perspective is very, very important. We cannot emphasize or stress enough how important it is to have a keratinized tissue around. Okay, number five, maintenance protocol, which is it has to be stringent. Whatever you want to use, whatever you want to use. Okay, I'm not sure if this is available. This is very, very useful to put the patient on 3 months recall. Okay, if the patient has a lot of inflammation and if the oral hygiene is very, very poor, you have to recall the patient every month. Okay, every month. So that would do. Okay, other different methods we can use, apply. Okay, this is super plus. Excuse me, I forgot that word at the beginning of the presentation. Okay, so these are many ways, but you have to have a customized way and your own way to have a maintenance protocol. Okay, so I think I am done. I think we can start accepting more questions that have been appeared through chat. Okay, I'm seeing one
So
question. Okay, okay,
we
you
have,
want to take a look?
yeah, so
Okay,
we
go
have
ahead.
very limited time, so we'll
Okay.
take only one question tonight.
Oh,
I've
I think
seen you,
we have. Yeah, yeah.
I've
I
seen
think we
you
could take
use
two. Yeah.
two
Okay.
more.
Yeah. Go ahead.
Okay. I've
Whatever.
seen you
Whatever. Yeah. Yeah. Okay.
a variety of tools. Will it have no effect on the surface of the implant?
No, it will have
We have,
effect. Okay, so I've
yeah, so
used
we have very limited
various
time,
tools.
so
I
we'll
think
take only one
each of them
question tonight.
have
I've
their
seen
own
you,
evidence. So
I've seen
PerioFlow,
you use
the
two more.
EMS made by EMS, they
A
have a
variety of
lot of
tools.
studies
Will it
that
have
have
no
been published
effect on
already
the
about
surface
the
of the
efficacy
implant?
of using this type of what do you call it? The spraying with the water and the glycine protein and also the air. So air abrasive units, I think they have a lot of evidence out there. So and also with the titanium brushes, they are starting to come up and building up evidence right now. So they have their own sets of evidence too. You look at mechanical debridement. I think there are plenty of paper in the literature, and also chemical ways. Tetracycline mixed with water, saline, and then we're utilizing gauze, and you're actually soaking in gauze, and then you're placing it in the affected decontaminated surface together with mechanical. So it's not alone. You cannot do chemical alone. You're mixing it with mechanical and chemical, and it's shown to have effectiveness. So it really depends on what type you would like. I think lasers also. Lasers are starting to build up evidence. There is some, but it's limited. It's limited and it's inconclusive also. But I think there are a lot of clinicians out there who are utilizing lasers too. So it really depends on you. And I think as time progresses, we are building up more evidence in this area. So although we don't have one definitive method that is much better than the others, I think there are a variety of ways we can utilize to efficiently decontaminate the surface. Uh, it's up to you. It's up to your preference, and it's up to what method you would like to actually perform the decontamination. Okay, I hope that helped. Okay, any more questions?
So on to our final question. Would grafting bone around the exposed and contaminated fixture actually allow regeneration?
Um, it has to have it has to be a favorable circumferential defect. So it has to be a contained defect, okay? And you need bone walls around to
Would
actually have
grafting
a
bone around the
successful,
exposed and contaminated
I should say,
fixture actually
you could
allow
say regeneration or
regeneration?
reconstruction. I think there is a debate right now. I think the newer generation of clinicians and scientists are beginning to, they like to call it reconstruction instead of regeneration, because it is difficult to actually have a conclusion, because there is a limitation. It's difficult to have biopsies in humans. Okay, it's just not ethical. So it we only have limited data of how much regeneration is done, or how much regeneration we get when we do these type of grafting, and also uh, the results are inconclusive, and it's just limited. However, there was one paper published last year, I think it was last year or the year before, by the Yonsei group in Korea. And it was a autopsy case, and I think the patient, after being seized, after passing away, has donated the body to the group, and they were able to I guess collect the samples of the regeneration attempt uh, in a very favorable defect configuration, and they were able to see regeneration. They were able to see successful regeneration with new bone to implant contacts. So we only have limited evidence really to support that. However, when we read that paper by the Yonsei group, they were able to see positive results from this type of regenerative challenge, as we say. Okay, so yeah, it depends. It depends. But uh, I don't know. I think it makes sense to call it reconstructive also, if you're really not comfortable. But the overall success rate, or the results, would have, I think, a significant correlation with the type of the defect configuration, and also defect characteristics. Okay. Okay.
So I think it's almost time to finish.
Okay.
Um,
So yeah. Oh, time passes by. Okay, this was a good opportunity for us. For me, I thank Dentium again for this opportunity. Okay, it was a pilot trial. I've Before the pandemic, I didn't know. I didn't even know what a Zoom was. I've never done this online, and now I'm starting to get more comfortable with this. But it's such a big honor to meet you guys, Indonesia. Hope Really hope that if this pandemic ends very soon, I would love to visit Indonesia and have a personal contact session or hands-on course, whatever. Hope Dentu could provide that for us. And I thank you for your precious time on a Friday night. Okay, thank you, and be well, and please stay safe. And until the time we meet, uh, thank you so much. Thank you. 감사합니다. Okay, bye bye.
Good night,
Have a great
everyone.
night, everybody. Bye bye. Dentu could provide that for us. And I thank you for your precious time on a Friday night. Okay. Thank you, and be well,
끊어줘도
and
될것
please
같아요.
stay safe. And until the time we meet, thank you so much. Thank you. 감사합니다. Okay. Bye bye.
Good night,
Have a great
everyone.
night, everybody. Bye bye. Dentu could provide that for us. And I thank you for your precious time on a Friday night. Okay. Thank you, and be well,
끊어줘도
and
될것
please
같아요.
stay safe. And until the time we meet, thank